everybody, this is Kevin with Nursing KAMP.com, and this is my Fishbone course focusing on potassium. We're going to cover the highs, the lows, and what you need to know. So let's get into it. This is the third video in this Fishbone lab course where I'm kind of covering all these electrolytes that are in this BMP. Sodium, potassium, chloride, CO2, and BUN, and creatinine, and also glucose. It comes from my Nursing Kamp clinical book found on nursingkamp.com or Etsy. So let's get right into it. Potassium and the BMP. And when we're looking at the BMP, we're looking at this fishbone diagram where I previously covered sodium. And I said that sodium is the only lab that you really need to know, and that is 135 to 145. Today we're going to talk about potassium. And to know what the potassium lab values are is that you go down 3, you go down here, 5, so 3.5, right? See, and then you take the 5 over here, and then you take the 1. But when you're looking at this column right here, this column right here is generally related to peeing, puking, pooping, drains, any relation to fluids. Now, if you're going to be tested on an electrolyte in the NCLEX or even in practice, what most likely is going to affect the patient is potassium and sodium. Some things to think about, especially with the NCLEX, is terms. Now, paresthesia right here is a term that means basically this itching, tingling sensation in the fingers and stuff like that. Now, as far as electrolytes are concerned, that's just the first signs and symptoms. But that could mean this is low potassium, this is high potassium, that high calcium, low calcium, magnesium. So when you see the words paresthesia, that just basically means that's the boat coming. In a previous video, we talked about how the boat is something that is potentially a problem. And paresthesia is a word that NCLEX likes to use in regards to, hey, there's something wrong with this patient. They need further assessment. Peripheral is another word that means around the mouth. So if they have paresthesia, peripheral-like symptoms, what they're really just saying is they have this numbness, tingling sensation. Means evaluate their lab values, and that's what you want to do, especially if you're giving something like Lasix. You give Lasix and they start having these signs and symptoms, or the patient's starting to have those signs and symptoms like circumoral, right, which means around the mouth, right? Circumoral paresthesia, if they have starts to have the signs and symptoms of these things, you don't give the Lasix, right? You need to evaluate, you know, what's going on with the patient. All right, before we start into potassium and really looking at this study sheet up here, what I wanted you to think about is signs and symptoms. We already talked about paresthesia and stuff like that, but what's specific about the concept behind potassium? When we're looking at the NCLEX doesn't expect you to have, you know, a memorized list, right? They expect you to have a concept. And the concept is this, is that with potassium, you should be able to generate your own list. And the basic rule for potassium is, you know, high is fast like symptoms, right? And then low is slow like symptoms, except for heart rate and urine output, right? And that's the basic premise. Now, heart rate is a little bit all over the place. It's a little bit gray out there. But the first sign and symptom is that, you know, when a patient has hyperkalemia, you should be able to generate your own list. So let's talk about that. So let's go from the head and move right on down, right? So the brain, fast-like symptoms, irritable, restless, agitation. All right, so let's go down to the lungs, right? So fast-like symptoms. So there'll be tachypnic, right? What about the heart? Well, we just said that except for heart rate, that would be low. Then we say, okay, well, what about urine output? Well, we also said that urine output would be low, right? So think about it. A high potassium patients, how does the potassium get out of the body? Well, it goes through the loop of Henle, right? And then it goes out, you know, through the kidneys. So if somebody has acute kidney injury or somebody has chronic kidney disease, as evidenced by the BUN and creatinine being elevated, they're going to have a high propensity for a high potassium, right? So what's the problem with high potassium is heart, right? And what I mean by that is cardiac arrest. The biggest risk of a hypokalemic patient is cardiac arrest. So you put that patient on a monitor. whenever you start to worry about hyperkalemia, you need to get that potassium off of that person. All right, so let's keep on going with the symptoms. So when you're looking at the bowels, all right, so they'll probably have diarrhea and, Borborygmi. Now, Borborygmi is another term, and Borborygmi means fast vowel sounds, right? Hyperactive vowel sounds. And I'll put the word down there and a little thing down there. Muscles. So do you think they'll be weak or are they going to be tense? Well, spasticity, these fast-like symptoms. And then reflexes. Will there be 0 1s or will they have 3 4s? They'll have 3 4s, right? Hyperreflexia. All right, so now that's pretty much decided. So that's fast-like symptoms. So what about low-like symptoms? Well, low is slow, except for heart rate and urine output, right? Well, heart rate's interesting because heart rate initially is fast, then it becomes low, all right? So, but, that's a little gray area. So hypokalemia. So let's start with the brain, all right? So they're going to be lethargic. What about the lungs? Bradykardia. What about the heart? We just talked about that, right? Except for heart rate, tachycardic. How about urine? Well, they're going to be polyuric. What about bowels? Slow-like symptoms, constipation. What about muscles? Well, they'll have flaccidity, right? Because hyper is fast-like symptoms. And then reflexes. These patients will have 0s and 1s. All right, so let's talk about how do you fix it? What do you do when a patient has low or high potassium? So let's take low first, right? Well, which one's more acute, low or high? Well, high is cardiac arrest, so that patient's more likely to have problems. Where low is bradykardia, respiratory arrest. So slow respiratory. And generally with low is we see that problem way before it actually starts to happen and we replace it. So let's take low first. So what's some causes of it, right? So we already said slow-like symptoms. So what could cause it? Well, we already know that the urine goes out by the kidneys. So therefore, the patient, so diuretics can cause this. So what I call is the 3 Ps, right? Which is peeing, diuretics, pooping, laxatives, diarrhea, all that stuff, and puking, anything coming out because potassium is all in the stomach, right? In the stomach, and if you have an NG tube in, that's going to take out all these potassium. So always monitor patients' potassium. So what do you do for a patient who has, low potassium? Well, you have to raise the potassium. You have to give the potassium. And the basic rule is you never ever push potassium. Never push IV potassium. It always goes on a pump. You only give 10 to 20 milliequivalents an hour. All right, so let's talk about this signs and symptoms list over here and what you'll see. So I said bradycardia. I said everything is low except for heart rate, right? I have bradycardia here because the heart rate, once you start to have a patient who is high, that's the beginning stage of hyperkalemia, hypokalemia. And all of a sudden, once they start to turn south, and there's a big issue here, they start to get bradycardic because everything starts to slow down. So if you see bradycardic with a hypokalemic patient, you missed the boat. I mean, that's called the doctor. Figure out what's going on. This patient needs replacements. All right, so respiratory arrest, slow-like symptoms. Alkalosis, respiratory, because think about it, right? So they're going to have an alkalotic system because potassium is an acid. So therefore, they're going to be hyperkalemic and they'll become acidotic. Ileus, paralytic ileus, slow-like symptoms. NG tubes because pulling all that potassium out. Hypoglycemia, nausea, vomiting, weakness, fatigue. Diuretics cause it. They'll have ST depressions because ST elevations are acute. Right? ST depressions is the boat coming. So put them on a monitor, the main thing is to prevent it from happening. So hypokalemia is preventable, right? So that's why we would check lab values before you give anything that's going to affect urine output, like Lasix, anything like that. So some other medications do cause problems with Lasix. Now, problems with potassium like Lasix, amphotericol, bicarb, and these medications should be monitored. Now, NCLEX will never test you on that. They'll always test you generally on symptomology, what the symptoms are, what do, put it on a pump, different things like that. All right, so let's take the next thing, and that is hyperkalemia. Well, in comparison between hypokalemia and hyperkalemia, I mean, hypokalemia, nurses will, clarify the order with the potassium, put it on a pump and all that stuff. But hyperkalemia, holy crap, there's a problem. Cardiac is the main issue, and so this patient needs to be on a monitor. So we're going to call him the King C, right? So the King C is Kayexelate, right? Now, Kayexelate is a little controversial. NCLEX will still test on it because what happens is whenever you have potassium, and potassium levels are all high, right? So they're all high outside the cells. And what happens is, we said that when we're looking at lab values, that is 3.5 to 5.1. So when we're talking about this, we're talking about all this potassium over here. So if we take the cell wall right here and we break it down, we'll have what's called a phospholipid layers, right? Which is the cell wall. You might remember this from A&P and such like that. So you have these phospholipids and these little tadpole-like things. That's a cell wall. Well, all this potassium is right here, and that's very caustic to the heart. And so that's why they start to get these peaked T waves. And these peak T waves is acute. So that's a first indicator. In actuality, when you're looking at potassium, there are some methods that you can actually see the level of this T wave, and you can estimate what their potassium level is. And that's pretty interesting, but you'll never use it. So we're talking about all this potassium outside that cell, and we're talking about Kayexelate, calling in the King C. Well, Kayexelate works on the colon, right? So what happens is you give it soupy poopy, right? So now what happens is, remember, peeing, pooping, or puking. Well, Kayexelate will pull potassium out through the colon, right? Makes them poop, so they'll lose some of this potassium. Now, there's a lot of controversy on this, a lot of different studies about this. It's not always used because of this. Like, people say it doesn't really work and different things like that. NCLEX still tests on it because NCLEX tends to be a little bit later on its content and until practice actually falls off. Because, the thing is like, would it hurt the patient? Or, just understand that it is something that is still used. All right, so the next thing is King, insulin, and glucose, right? So what does that mean? Well, glucose is a big molecule, and what happens is insulin is circulating around, and insulin takes glucose and brings it into the cell. And the way that it does that, it binds to this, and so what happens is that it binds through the glucose with the insulin, and it basically moves into the cell. And what it does is it goes in between these layers. And so what I think a lot is that as it moves in, potassium falls in with it. And that's kind of how it happens. So then inadvertently, from giving all this glucose and insulin, all of a sudden, the bioavailability of this glucose will start to push into the cells, and all this potassium will start to move into the cells. And basically how it does is it pulls it in and all this potassium. So the potassium starts to decrease. And in an acute situation, patient's going to have a heart attack. We need to decrease that potassium very quickly, and that's how we do it. So we call him the King C. And what's the C? Well, the C is calcium gluconate. Calcium, go, go, go. Gluconate is good to go. So calcium does the same thing. So on the cells, you have calcium channels, right? And so what happens is that what calcium does is calcium potentiates and moves the to the cells, and to bring, and inadvertently will start to decrease and cause more channels to then start to allow for potassium to go into the cells. Now, Does that affect the cells and stuff like that? That's not important. The most important is to get rid of this hyperkalemia that's outside the cells. All right, so let's talk about it. So hyperkalemia is acute because you got to put them on a monitor because they could get a cardiac arrest. So we need to call in the King C, Kayexelate, insulin, glucose, and maybe calcium gluconate. Sometimes you see calcium chloride. Now, calcium chloride is caustic to the veins, so it needs to go through a triple lumen. So you tend to see calcium gluconate most likely, and a lot of times on crash cuts we see calcium chloride. All right, so what's some other things, right, with hyperkalemia? Well, you do have meds, and meds can become a problem. Like aspirin causes, think about it, potassium acid, acrylic acid, and potassium as well, right? Lithium, right? So lithium also causes hyperkalemia. So they need to be monitored for this. And we talked about that with sodium, right? We said sodium and fluids is very important with lithium patients. Enalapril, so ACE inhibitors, right? In my other lecture, I talk about ACE King High. And ACE King High is a mnemonic that for all ACE inhibitors. So what do you monitor for ACE inhibitors? Well, K, King High, potassium high. This other is angioedema. They get this cough, and E for electrolyte, potassium high. All right, so why this picture, right? So one of the big things about potassium, and I really wanted to cover this because of, potassium is cardiac arrest, and that's what we really start to worry about. But the advanced thing is we have to monitor that patient. So that patient should be on a monitor. And so what's the issue, right? So we have to say, okay, well, potassium kicks, right? So contractility, ultimately they can go into VTAC, right? And that's a problem because VTAC is shockable, and that's cardiac arrest. But what's the key to recognizing it before it happens? Well, you have three different aspects that you're going to have, right? So the first thing is your peaked T wave, right? So PQRST, right? So that T wave is going to be peaked, right? And the way I like to think about this is the wave is high, right? The QRS is wide, as the white wave goes across, and then it flattens out, right? So the wave is high, so peak T wave is high, the QRS is wide, and then it flattens out, so the flattened PR, right? And that's a sign of hyperkalemia. Well, what about hypokalemia? Is hypokalemia important as far as cardiac wise? Well, no, it's mainly respiratory, right? So we said that it's mainly respiratory arrest. That's the issue that we tend to think about. But there can be some changes on the ECG. So what are we monitoring? We're monitoring lead 2 or V1. Right, that's what we do, because that's the best picture that we can look at the ventricle, what's going on with the heart. And please see my cardiac lectures where I really talk about that and how to really look at ECG leads. All right, so let's talk about hypokalemia. All right, well, in my ECG lectures, I talked about two different sides of this ECG. And we said that this side is chronic and then this side is acute. So anything over here is acute, like peak T waves is acute. Well, P wave is not really that acute. It means there's a potential problem happening. And generally you'll have, if you think about what potassium does, it helps with contractility because hyperkalemia is fast-like symptoms. So therefore, if somebody doesn't have enough potassium, they'll have slow-like symptoms. So they can have less contractility, and that PR will be slow, right? It's going to be prolonged, which means that this contractility is going to be slowed down. And what happened is that you will get also a peaked P wave. Well, if you know that hyperkalemia is peak T waves, right? The wave to the wide to the flat. The hypokalemia is on this side. It's the chronic side, so it's not as acute. So peaked P wave instead of peaked T wave. So what will the T wave look like? Well, if we knew that the opposite of, flattened PR on hyperkalemia, then you're going to have a flattened T wave. And that's on this side. And that's a sign of hypokalemia. Now, NCLEX will never ever test you on ECG. So if do you need to know it? This side, I think it's good to know. It's a little bit nuts to know. And but it is important. And that's why we look at, hyperkalemia as a priority for cardiac arrest. All right, so let's break it all down. What do you need to know, right? So you need to know the signs and symptoms so we're moving to the NCLEX, and you need to know the signs and symptoms of it. Now, over the fences for the NCLEX, what you need to know is that all symptoms are for hyperkalemia fast-like symptoms, except for heart rate and urine output. And then for low, what do you need to know? Well, all slow-like symptoms, and except for heart rate and urine output. So that you could generate your own list, and that's the basic concept. Okay, now which one's more acute? Acute low or acute high? Well, low is see the problem, do assessments, prevent it from happening. Don't give Lasix, don't do those things. High is, holy crap, we need to do something, call them the King C, and Kayexelate, insulin, glucose, calcium, gluconate, chloride. And what else do we worry about? Well, I mean, what if you don't have calcium, gluconate, and all those type of things? Hemodialysis, that's another thing, right? So you can give hemodialysis and emergent hemodialysis. The main thing is that potassium high is acute, acute, acute. So let's talk about the numbers, right? So we said 3.5 to 5.1. And we said that 5.1 to 5.5 is generally, something's happening. Why isn't this patient getting rid of this if they have normal kidney functioning? Why aren't they getting rid of this potassium? So then we start to monitor closely, put them on a monitor, we'll notify the doctor, different things. NCLEX will generally test you greater than 6, greater than 5.5. 5.5 to 6, then 6 and above is definitely acute. Get the doctor on the phone, figure out what you need to do, anticipate these orders, King C, hemodialysis. Right? Low is prevent it from happening, right? So 3.0 to 3.5 is you don't give Lasix. Anything that's going to affect peeing, puking, and pooping. If they have an NG tube and they have a low potassium, obviously it's the NG tube, right? So what else? NCLEX, when it comes down to looking at for the NCLEX and potassium, mainly it's the main electrolyte imbalances that you're tested on, because it can really affect the heart, and that's going to be a big issue. And that's what they want, because you're going to get a lot of hemodialysis patients in your career, and you're going to give a lot of Lasix. So it tends to be a very highly testable electrolyte. And out of all of them, those are the main ones that you need to know, because as we move on, we're going to go to chloride and CO2. Now those play more into practice, not so much into NCLEX. So let's move on to the concept and bring it all together. All right, so in this concept process, we're going to look at, who has, hyperkalemia, right, or hypokalemia? Well, peeing, puking, or pooping. So somebody walking around, a hemodialysis patient can have hyperkalemia. So that's why we will, they'll need to know those signs and symptoms of it. That's why they need dialysis every other day, because the risk is cardiac arrest. They could be, being taught about this. They could also be coming in cardiac arrest. They always with patients on the floor, we're going to be monitoring potassium because it is part of this BMP right here. Now the symptoms 3 are very specific to high versus low. Always precipitating is if patient has kidney problems, you're going to precipitate somebody who is high. If a patient is peeing, puking, or pooping or has an NG tube, you're going to anticipate low. So the main concept is, potassium is usually regulated to symptomology and what's going on with the patients. What's the main complication? Well, low is respiratory arrest, because low is slow. And high is cardiac arrest. So notify the doctor, especially about lab values, if they are out of the ordinary, and if they are complicated by medications that you might be giving. Always give peripherally 10 milliliter equivalents an hour, 20 through a central line. Potassium works a lot with sodium and chloride and CO2 in the balance. And if the BUN and creatinine are elevated, then before the kidneys are affected. All right, so will they be on a monitor? Hyperkalemia, yes. Blood pressure will be affected. Well, they'll be hypertensive with high and hypotensive, because remember, high is fast. So is this. Labs are, that's what we're talking about. Positioning, not so priority. Diagnostic test, no. Maybe an EKG, right? So an EKG if the patient is hypokalemic, but this patient will definitely be on a monitor. Definitely they need treatment, and medications a lot of times the cause. It affects the brain. We talked about the lungs, heart, kidneys. And so temperature, right? So if you were to think about it, hyperkalemia, would it be a high temperature or low temperature? Get it? So it would be high. So there we go. So then we talked about heart rate, except for heart rate would be, the opposite. Respirations we talked about, and BP, mean arterial pressure, or pulse ox. So fluid status is big on hyperkalemia and hypokalemia. Pulses related to dehydration or what have you. Cardiac labs, yeah, mainly, troponins, different things like that. Cardiac arrest. Calcium, mag, not really. Liver, no. WBCs, no. Platelets, no. All right, so ABGs, no. A lot of brain irritability for high. But remember, paresthesia are generic terms. Heart, definitely. Lungs, we talked about, and kidneys, we talked about. A lot of times patients can be treated and sent home. So that's why it becomes a highly testable thing. A lot of times they'll be discharged. Depending on the potassium level, they might be on a med search for. Med search for would generally have hypokalemia, where hyperkalemia will go to a tele for. ICU definitely on a tele with hyperkalemia, and when we're having to give Kayexelate, insulin, glucose, and all those types of things. So definitely CCU. And generally the patients can recover, you treat the underlying cause. Well, that's about it. My name is Kamp, and this is Nursing Kamp, and from nursingkamp.com. This is from my Fishbone course and found from my Fishbone book, where I'm covering all the labs in that Fishbone. When you're looking at potassium, always think about, potassium is acute. And of all the electrolytes that you really need to know, this is the one that you need to know. So we'll see you next time, where we talk about chloride and CO2 and BUN and creatinine and glucose. See you next time.